Okay, good morning, everybody. Sounds good? Yep, perfect. Okay, thank you very much. Cool. I think pretty much everybody's here, so we'll make a start. Morning, everybody. Hope you had a good sleep and a good breakfast. Ready for another day sitting in a dark room, listening to my voice. So we're going to talk this morning about a specific area where we find IVUS to be particularly useful, and as we were talking about yesterday, to influence our decision making a little bit more and guide our decision making. And Mark hinted at this when he quoted the Korean study that noted that actually they found that the IVUS, the benefit conferred by IVUS use was more pronounced in patients with task C and D lesions, and that kind of a little bit hints about what we're going to talk today, that when you're dealing with complex calcified lesions, having that ability to have a little bit more information about the lesion that you're treating can help guide your device choice and device use. So this, just by way of introduction, I don't need to really tell anybody here about this, but the problems caused by calcium can be intraprocedural, which is acute recoil, flow-limiting dissection. You've got a much higher risk of requiring to do a bailout stent if you're working in the femoropopliteal segment. And the problem with that in CLTI is that CLTI patients frequently have an impaired tibial runoff compared to claudicants, and it is well established that the more runoff vessels you have for a femoropopliteal stent, the more chance it's going to stay open for longer. So we end up being forced into situations where we have to stent in calcified lesions in the FemPop segment, where we don't really want to, and we know that the conditions for that stent to live long are not really there. Calcium can also bring risk of distal embolization, and in CLTI again, this is particularly poorly tolerated because, as we said, these patients have an impaired tibial runoff anyway. They may only have one functioning tibial artery going into the foot, and if that embolizes, then obviously you have a problem. And then finally, vessel perforation is rare, but again can happen, particularly in the setting of heavily calcified lesions. Post-procedure, we can get subacute recoil, and calcium also brings with it a poor absorption of anti-restenotic drugs. So then we have to, not only do we have a stent that we've placed in a FemPop segment with poor runoff that's more likely to restenose early, managing that restenosis is then going to be even more difficult because we can't get our paclitaxel or sirolimus into the artery wall. So what's the solution? Well, this is where vessel preparation really comes into its own. And what we're aiming to do with vessel preparation is to alter the quality of the calcium to improve its response to eventual balloon angioplasty. And that's really the root of what vessel preparation is. So the specific aims of these vessel prep technologies are to debulk superficial calcium. We want to put cracks into the superficial and the deep calcium. If we've got nodular lumps of calcium that are coming into the lumen, we want to flatten those out. And we're hoping all the time with these microfractures to improve anti-restenotic drug uptake through the wall of the artery. So how do we image calcium? Well, preoperative CT scans can give you a good appreciation of calcium density and an indication of what its distribution is in terms of whether it's nodular, whether it's medial. But in the setting of heavy calcium, you often have too much artifact to accurately assess the lumen. In patients with chronic kidney disease, we also want to avoid using contrast, but I have to say that as I've been doing more and more, using more and more vessel prep technologies for calcium, if the patient renal function precludes them having a CT scan with contrast, sometimes I may even just get a non-contrast CT just to give me a little bit of a guide as to where the calcium is, what the density of it is, and start to make some predictions about how much it's going to need modifying during our treatment. Duplex, well, the problem with duplex always is that the ultrasound beam is coming from the outside. So in the setting of really heavy medial calcium, you get this kind of curtain that's thrown over the whole artery, and you're looking for little gaps in the calcium to try and get a velocity somewhere up and down the vessel that you're measuring. And you can say the SFA is heavily calcified, but it doesn't really give you any more information than that in terms of usefulness with procedure planning. Intraoperatively, we use fluoroscopy, but again, that's only a 2D view of calcium. And if you have a look at this picture here, you can see that clearly a PAX 4 in terms of calcium classification, with calcium up and down both sides of the artery, SFA, FEMPOT, profunda, all branches. You can hint that there might be some more nodular lumps of calcium here and here, but when you actually look at the angiogram, most of that vessel is patent apart from 2 focal lesions. And this is one of the problems that we have with, for example, the PAX classification, that when you have a classification system for anything, it's a bit like setting an exam for students where every single student gets an A star, apart from one who gets an A. That's not really a very useful exam, because if everybody's passing or getting a high mark, it doesn't differentiate between the students. And a lot of these calcium classifications are the same. If everybody is PAX 4, that's not really giving you much useful information. So what options do we have to vessel prep in the setting of heavy calcium? Well, really, over the years, it's come down to 2 main things, and the first one is atherectomy. With atherectomy, you obviously have to be intraluminal, and this is where IVUS can help us a lot. Again, if you look back at some of the earlier atherectomy trials, you would see a sort of perforation rate of between 3 and 5%, and you have to remember that a lot of those trials, most of the patients were done without the benefit of IVUS. In our experience, when we started sort of mandating IVUS use before doing atherectomy, our perforation rates dropped way down. In fact, I can only think of one case that I know we've only had one case of perforation with Phoenix atherectomy, particularly before we started, since we started using IVUS, whereas we'd had maybe 3 or 4 out of 60 cases before that. Using IVUS just guarantees that your wire is intraluminal before you put a device with blades into the artery. The issue with atherectomy and assessing how well you've done is it's very difficult to assess lumen gain on single plane DSA after atherectomy. You may see a channel formed, but again, without multiple projections, you don't really get an idea of how much of a channel you've created. With intravascular lithotripsy, the issue we have in calcium is you need to size really accurately, particularly in the setting of nodular calcium. So the point of oversizing in intravascular lithotripsy is obviously to get the IVL balloon to mold all the way around the calcium to make sure that all surfaces of these calcified nodules are in full contact with the balloon, so that you get really good transmission of the energy from the emitters into the calcium. And the IFU mandates sizing at least 1.1 to 1. I happily oversize way over that, and especially in the setting of multiple nodules of calcium, I'll happily oversize by 20%, 30%, just to get a good apposition of the balloon fabric onto the calcium. But the issue that we have with IVL particularly is assessing lumen gain after delivery of the energy is even more difficult, because with IVL you have to remember we're not removing the calcium, we're just cracking it and making it respond better to angioplasty. So again, with DSA it's very difficult to assess the lumen gain in the immediate setting and know whether you should be using more cycles of IVL at one location or whether you should move the balloon to the next location because that one's done enough. Calcium scoring on fluoroscopy, again, Mark alluded to this yesterday. There's some data out there which really kind of tells us how unreliable or how fluoroscopy can underestimate the calcium load in patients. So this American series looked at 47 cases comparing quantitative vascular analysis, vessel analysis from the fluoroscopy package, angiography data with IVUS, and they compared against all of these well-known calcium scores that have all been used in different trials over the years. PAX has probably come out as the winner that most people use now, but PARC and definitive calcium scores were used in sort of pretty big atherectomy trials over the last 10 years. IVUS, looking for calcium, looking whether it's superficial, deep, mixed plaques, lesion length, etc. And they found that in 94% of cases, they found calcium on IVUS, whereas only 55% of cases on angiography. The Allen group in Adelaide, again, showed comparing PAX, PARC and Finelli calcium scores with IVUS looking at the maximum calcium arc and length. And again, what we can see is that while the specificity of PARC and the Finelli classification particularly is high, it's still the sensitivity and specificity of any of these scores don't approach anywhere near what IVUS can tell you about calcium within the vessel. So we have this problem of calcium. We have potentially some tools to deal with it with atherectomy and IVL, but what we really don't have is, or didn't have until we had IVUS, was a good way of assessing the right tool and how well that tool is working. So I'm going to show you some cases just to show in practice how IVUS helps us assess that, and maybe gain some insights about what these tools are doing to the vessel wall when we're using them, and how that guides our treatment. So this patient is 79 years old. She's deaf. She's got night pain, rest pain, and very short distance claudication. Can't really get out of her house. She's had bilateral common femoral end arterectomies 5 years ago, PCI 5 years ago with coronary stents placed, and she's got COPD, type 2 diabetes, high blood pressure, etc., and some benign renal tumours that we're just keeping an eye on. This is her initial angiogram, so you can see there's multifocal stenosis up and down the SFA, and you can see on the plane map that again she's on the mask image that she's definitely a PAX 4 in terms of the calcium load, if we're using those fluoroscopy scores, and you can see she's got 2 vessel runoff with PT and perineal, and the perineal reconstitutes the distal anterior tibial artery going into the foot. Easy to cross this kind of lesion, the wire just flies down, and we put the IVUS through to mark where we find healthy distal vessel and healthy proximal vessel to guide where we're going to use our intravascular lithotripsy, which is what we chose for this. We get a vessel diameter here. I size a little bit more, a little bit bigger now with experience. Before I used to measure from the intima, but now I would take this out a little bit further and measure around the media as a pretty good guide of how to size the vessel. I think I was talking about this with JJ yesterday, that I think the way the cardiologists do this about sizing to the external elastic lamina, I think that's a bit too aggressive in our setting, because you have to remember that the cardiologist will almost always be stenting these vessels. So oversizing or erring on the side of oversizing doesn't matter so much, because if the vessel dissects, you're going to be stenting it anyway, whereas we are often using these technologies to try and avoid stenting. Shockwave don't give you any suggestion about what you should do with an IVUS. Yeah, that was because I told them to. They don't give an idea about what to do with the IVUS because it's not their product, right? So it's kind of yeah, that's not from Shockwave per se, but yeah. So media to media, you can see here, this is the case I showed you with some positive remodeling here, and we choose a Shockwave catheter there, the 6mm, to oversize by at least 1.1, and you can see that familiar picture of the catheter opening up with some stenosis in it as we take it back, and then it pops out as you get over time, and then a plain balloon angioplasty and a drug-coated balloon angioplasty. And what I want to show you here is IVUS grabs from the same area, the same lesion, at different points after different stages of the treatment. And just to understand a little bit about what's happening here. So if you look at this image here, this is pre-IVL. If you measure the stenosis on a single image by measuring the cross-sectional area, then it's 62%. The overall vessel cross-section area is 18mm. The vessel diameter is this. And the lumen area, just purely by area, is this. After IVL, the stenosis, the percentage stenosis has stayed the same, but the overall vessel cross-sectional area has increased. So how can this be? So if you have calcium in the wall of an artery, that sclerosis effect that it causes on the media causes the muscle layer in the media to be sclerosed and scarred and tightly shut. Whereas if you crack that calcium, that muscle is then allowed to relax and go back to being what it is, which is a responsive muscle layer, and the artery can just relax and open out a bit, and the diameter of the vessel overall increases. And then you get some gain in lumen area after just the IVL, but then you see once you do a plain balloon angioplasty again after modifying the calcium, because this is vessel preparation, and then you do the plain balloon angioplasty after that, then you will see that the stenosis reduces to 35%. The overall vessel cross-section area has increased even further as we've stretched out with more pressure. The vessel and the vessel diameter has gone up to 5.7. So you can see just in the course of the treatment, because you're modifying this calcium and changing the compliance of the vessel, you can actually measure this increase in diameter in the artery. And we'll show that on another segment where I've got the images for all all three stages, that again, in a different part of the SFA, you can see we start with a 67% stenosis. The overall vessel cross-sectional area is 19 millimeters with a 5 millimeter diameter. After IVL, the stenosis has improved slightly, but this is just after IVL. The overall vessel cross-sectional area is increased a little bit with a obvious increase in diameter, but then after the plain balloon angioplasty, again, that same plaque pushes out and the vessel in the same place has actually got bigger again, up to 5.7 millimeters. You can see now this is the kind of difference in size that will influence our choice of DCB. So as we were starting to use this more often and assess with IVUS after IVL, I started realizing that just doing one IVUS run at the beginning and basing all your sizes on that might lead to you undersizing further down the line. So now what we do is we'll do the IVL, we'll do a plain balloon angioplasty, and then we'll run the IVUS through again, because more often than not, we'll, in the setting of heavy calcium, particularly medial calcium, we'll find that the artery has actually grown as you've changed the compliance of the artery by cracking that medial calcium, and it just relaxes out and opens up a little bigger, and often leads to a change in our choice of the size of DCB. That's something we see on pictures. What does that mean in practice? Well, in practice, that changes a vessel that might just have a sort of monophasic flow or a weak pulse to a really good, strong pulse with a biphasic waveform, if you've got the ability for that media to suddenly sort of open and snap back. And this is the angiographic result. And you can see good flow there. Checking just at the top, coming out of that common femoral patch to make sure there's no stenosis there, and you can see the runoff has been preserved. And you can see before, these cases often would come with a little bit more risk, because you can imagine just with that heavy calcium, by hitting those with just plain balloon angioplasty without vessel preparation, you're likely to end up with a scenario of multiple dissections, and there's quite a high chance that you would be ended up forcing to stent there in a situation where you don't want to. This patient doesn't really have tissue, doesn't have any tissue loss, so I would rather avoid stenting patients who don't have a wound, if at all possible, and that's what we were able to do in this case with vessel prep. Let's look at another tibial case. Again, looking at how IVL can modify the calcium and change the compliance. So this is a patient who is in their late 70s, is obese, type 2 diabetic, various medical problems, including atrial fibrillation, heart failure with a reduced ejection fraction of 30%, but pretty functional as it goes. You can see he's got that classic diabetic pattern of disease with wide open fem-pop segment, but then in the tibials is where things start to get interesting. So he's got CLTI with rest pain and a necrotic left hallux, and you can see he's got this good AT that's coming down, but the TPT looks tightly stenosed, and we can see some PT here, but it's not really filling so well. The perineal's not really there. If we look on the mask image just to assess, you can see there is evidence of some calcium here, but actually this doesn't look too bad. There's a few bits of calcium here and there, but it's not terrible. Looking down into the foot, you can see that AT kind of peters out and the DP is very small. We can guess that the PT may be our best vessel into the foot, because you can see actually the lateral plantar is quite good and is feeding much of a pedal arch here. But I'd point out to you that there's few areas here where you can see this tight stenosis within the PT. And those lesions can be sometimes quite significant and quite difficult to deal with, more difficult than they might appear just on the initial angiogram in terms of tracking devices through. So first of all, we looked at the TPT lesion, deciding what to do. And as you can see on this TPT lesion is not calcified at all. There's a little bit of calcium just in the wall, but the majority of this stuff is soft plaque or even thrombotic material. So what we did here is we don't need to use any calcium modifying technologies here, because the calcium in this segment is not a factor. This IVUS image is from here and this is here. So we do a 4 millimeter balloon angioplasty, just slightly undersized, and then we're going to reassess that lesion. But after that balloon angioplasty, you can see the flow is significantly improved, but there's still some residual stuff here that we can assess later on the IVUS and decide what to do. Then when we go down into the foot, I couldn't really track the IVUS catheter all the way down, so we had to do some pre-dilation, as we were talking yesterday. I've just learnt over time about how much is too much to push. And in this case, I was having to push a little bit too hard, so we backed off. We were able to get the IVUS catheter down to here, but no further. This is the location of that tight stenosis that I showed you on the first angiogram. So in this case, we actually went up with a 2.5 millimeter balloon angioplasty here, and then the IVUS catheter was able to track all the way down into the foot, and we get a measurement with the IVUS reference vessel diameter of 3 millimeters, and we decide that's what we're going to go for. There was much more calcium present in multiple locations in the PT, so we chose to use a 3.5 millimeter IVL catheter and use that to deliver the energy all the way down the vessel, as you'll see here, starting from distal to proximal. And when you put these IVL catheters in, it's important to definitely work distal to proximal, because once it's inflated for the first time, then it'll be more difficult to track it through lesions. So you want to get it while it's still nicely wrapped as distal as possible, and then work your way back. So that's what we did here, all the way up the posterior tibial artery to the origin. And then, because we've decided from the pre-IVUS that the size is 3 millimeters, we've gone with a 3 millimeter plain balloon angioplasty all the way down the PT. This is the angiographic result. So you can see really nice flow down the PT now, and the vessel has really opened out nicely, good flow into the foot, no evidence of distal embolization on these angiograms. And now we do an AP foot view to confirm that the PT is actually really the best vessel that's going to give flow out to the hallux, which is where we want it all to come to. And you can see here the lateral plantar artery is a bit small, but the medial plantar is giving some good flow out towards the hallux. So this PT is definitely the target that we're going to put all our money on. Assessing the vessel again with IVUS, you can see at multiple locations we were noticing these cracks that have happened in the medial calcium, but there was one particular area where you can see there's a little focus of dissection of the soft plaque that's actually dissected there. And what was interesting here is that the vessel, despite only being angioplastied up to 3 millimeters, was now measuring close to 4 millimeters on IVUS. And the reason for that, again, is this medial calcification is cracked. You take that choke off the artery almost and just allow it to relax back to its full size. So when we saw this area of dissection here, we tacked that with a spot stent. So this is just a drug-eluting stent, a very short 4 millimeter drug-eluting stent over that area to hold that flat back. And then look back at our TPT lesion, and you can see this soft plaque has kind of moved across a little bit, and you can see why the flow looks better in angiography, but obviously this is a lesion that we can't leave. So at this point we make a decision to place a stent there, and placed a 6 millimeter by 24 formula stent, so just a balloon mounted uncovered stent, after having put a drug coated balloon onto that artery to reduce the risk of restenosis there. And that's the IVUS showing that the stent has actually opened out really nicely now, and this compared to this, we've got a really solid, really good lumen here with that plaque pushed over to the side. Again, just checking to make sure there's been no distal embolization, and you can see there's really good flow down the PT now and into the foot. This patient I don't have a full IVUS pullback for at the end because he was starting to move a lot on the table, so it's difficult to get good images. But what I do want to show you is this one. And this is the IVUS catheter positioned in the PT just above the ankle level, and you can see that the vessel itself is now pulsing because, again, you've cracked that medial calcium and you've allowed the media to respond to a pulsatile waveform in the way that it normally should. And as we know, if you've got a good pulse, that's much more likely to mean you're going to get good wound healing, because it means you've got that really good pulsatile flow out into the wound bed. So that's IVL. Let's talk a little bit about atherectomy before we finish. So what I want to take you through is a series of 3 papers put out by Prakash Krishnan, a cardiologist in the States, looking in a very systematic way about atherectomy and what we can learn about atherectomy and why atherectomy works well in certain cases and how we can do safer atherectomy. So this series of papers came out over the last over the last 10 years. The first paper was where they sent all the effluent that you got in the collection bag after atherectomy off for histological analysis to see what tissue you had in there. Did you have intima, media, or adventitia, or all 3 in the atherectomy effluent? And what they found was that if you have evidence of medial and definitely adventitial injury in the atherectomy effluent, you had a much, much higher rate of 1-year restenosis. So the whole cohort incidence of restenosis at 1 year was 57%. But of that, actually, 97% of the patients were patients who had histological evidence of adventitial or medial injury in the atherectomy effluent, whereas those who you can do atherectomy without injuring the media or the adventitia, the restenosis rate at 1 year was only 11%. So this is the first thing that was telling us yesterday when we were talking about the eye dissection classification. this is now a little bit of evidence that we can use to guide how we manage the dissections that we see. That if you've got a deeper injury into the arterial wall after atherectomy, you're more likely to have restenosis. The next paper that they put out showed that IVUS can actually predict a little bit this adventitial or medial injury that you're seeing on the histology. And they were able to link in the IVUS findings of dissection going into these layers with the histopathological findings of adventitia or media in the atherectomy effluent. And then the final paper that came out in 2018 was putting those two things together and actually tying this to clinical outcomes. So this was about 100 patients, directional atherectomy for FEMPOP in-stent restenosis with or without IVUS. And they found that with the patients who have IVUS-guided atherectomy, the clinically driven TLR rate was significantly lower versus those that had just angiographically delivered treatment, and the lack of IVUS guidance was a significant predictor of clinically driven TLR. So what this tells us that in the two situations where we often use atherectomy, first of all, if you have medial injury that you can see on IVUS, that you're more likely to get restenosis, and that when the other setting that we use atherectomy in is in-stent restenosis, that in these patients, again, the IVUS guidance might help you to get a better result and reduce your CDTLR rate. So I found these three studies quite helpful to guide how we use the information that we get from the IVUS in our treatment. So obviously in those cases, we're more likely to use a bailout stent in the injured segment. This is a patient, 72 years old, not very fit, severe COPD, and he'd just come out of intensive care with a community-acquired pneumonia and type 1 respiratory failure with a slow tracheostomy wean. So he's obviously a really high-risk patient for open surgery, although you would say that this kind of coral reef lesion in the common femorals is a lesion that we would, in those days, would normally have approached with open surgery, but he was really high risk, so we decided to do something endovascular coming from up and over. This is how it looked on angiogram. You can see it's very, very tight stenosis, but essentially it's a functional occlusion. There's probably a little lumen there, but it's behaving like an occlusion. It's relatively straightforward to cross. Placed a filter in the proximal SFA. This is the initial IVUS pullback. You can see this is really slow flow, and then we're into this calcified nodular lesion here. We can see we're intraluminal all the way, but the IVUS catheter is literally just squashed between this big lump of calcium and the wall. But reassuringly, we can see all three layers of the artery on the other side away from the calcium, so we know we're intraluminal. This happened to use Jetstream for this case. It was quite a while back, and worked our way, obviously not that fast, through the lesion, really, really, really slowly, sort of that pecking technique, just going backwards and forwards a little bit, and that created this initial channel. This is the IVUS after the first, and now you can see we've created that channel. It's much more visible around, and then what's also happened here is that you can see much more evidence of reverberation behind the inner layer of calcium. So it's not just one shadow, one bright line with complete shadowing behind it. There's much more reverberation behind it, and that's giving us a hint about the calcium modification that we've done. We've not just debulked, but those fractures in the calcium have modified its structure and made it more likely to respond to balloon angioplasty, which we then did. In this kind of case, just because of his tissue loss, and I didn't really want to have him on table again anytime soon, so I wanted to be sure that this would last. I decided to place a stent to keep it open until at least he'd got his chest a little bit better if we have to come for any reintervention. So I ended up placing a supera stent here, and it was really easy to deploy and opened out nicely after the vessel preparation. His wounds had healed by 6 months, and the stent was patent right up until his death. Actually, he survived, I think, another 3 years after this, and then died with a patent stent on his last follow-up. One last case, so sometimes just one vessel prep isn't enough. This was a 68-year-old type 2 diabetic who was continuing to smoke, terrible history of heart disease, and presented to us with rest pain and these infected interdigital ulcers. And he essentially told me that he was not going to quit smoking. We had a long chat before the procedure, and he just said, look, this is one thing I enjoy left doing in my life, I'm not going to quit. Annoyingly, he'd also had a CT scan done that was supposed to be done a week before because he had a bit of sort of chronic kidney disease. GFR was okay, but sort of 40-ish around that. But the CT had somehow been delayed and happened on the morning that he came for the procedure. So he just had one dose of contrast, so I knew we were going to have to be a little bit careful with contrast for this case. Because of his heart problems, he's very high risk for general anaesthetic. So we did the procedure with a popliteal nerve block for the rest pain and just a remifentanil infusion for comfort and mild sedation. We were able to talk with this sort of sedation approach where it's kind of sedation, analgesia, more analgesia than sedation really. You can still talk, you can kind of wake them up and they're rousable and talk to them, but they stay still enough for you to do your work. Because of the dose of contrast, I wanted, you can see in his bladder there, we wanted to minimize the amount of contrast that we're giving to the procedure. His CT scan showed a left distal SFA popliteal occlusion and some iliac disease, which we were going to have to come up and over from the right groin to treat the left-sided disease. But because of this iliac disease, we knew we were going to have to treat the iliacs in order to safely get a crossover sheath in to treat the left leg. There was some disease in the left common femoral artery and SFA, which meant that we couldn't go antegrade in the left leg. His arteries were also quite small on CT, so we decided to just use IVUS guidance for as much of the first part of the procedure as possible to minimize the contrast load rather than doing angiograms here. So you get access on this side, wire up, IVUS in and mark positions. So here's the pullback coming down from the aorta. You can see there's some calcified stenoses there, back down into the sheath there and out. We pop the IVUS in to mark where our stent landing zones are going to be and get some diameters. Upsize the sheath here and placed, first of all, a self-expanding bare metal stent in the external iliac artery to allow us to get a slightly bigger sheath up. Mark again the iliac bifurcation, the aortic bifurcation with IVUS. Placed a VBX stent here because there was a significant step off in vessel diameter between the proximal common iliac artery and the distal, and we wanted the ability to overdilate it. So then we overdilated the top end of that VBX to 10, let it gently taper down to 8 here. Post-dilated our external iliac artery stent. Again, we've not done any angiograms here because we trust the IVUS enough to know we know what the rough geography of the vessel is from the CT, but we can just trust with the IVUS with each kind of, doing each kind of mark point. And then finally, once we've got our stents in and post-dilated, this is just with 2 mils of contrast, a quick angiogram just to ensure that we've got flow. And now we know that we've treated this side enough, we can safely go up and over into the left leg, which is the one that we really want to treat. This is an IVUS pullback from the left side going into the right side. So there's the IVUS catheter coming back. There it flips over the aortic bifurcation and back into our stent, you can see. So this is again the left side, pulling back left external iliac into the left common iliac artery, and you'll see it flip over the aortic bifurcation just there and into the stent that we've put on the right side. So again, using what we did on the right, on the left, we mark where the maximal stenosis is in the left external iliac artery. IVUS there. IVUS there, we want to stent between those, landing healthy to healthy. There's our self-expanding bare metal stent placed, post-dilated, and again another 2 mils of contrast just to show we've got flow, and then we're able to take our crossover sheath over nicely into the left external iliac artery, and now we're ready to do our further treatment with just a very tiny amount of contrast given. Again, some runs of the SFA with dilute contrast. You can see there's a bit of stenosis proximally, and then in the distal SFA and P1 just going into P2 popliteal artery, there's a complete occlusion, and then 3 vessel runoff going into the foot. But these arteries are all heavily calcified, quite gracile, but there is actually a good pedal arch. You can get an idea about the calcium here, seeing how the IVUS catheter have to push through just to get through there, everything very tight. But this one we were able to go in without any predilation, and this is the pullback. So you can see this CTO is actually composed of 2 different components. We've got the heavily calcified nodular calcium, which is coming into the artery, and we've also got some softer plaque that's mixed in with that as well. So we decided to go with atherectomy in this case, and after rotational atherectomy here, you can see I'd lost the wire at some point during the atherectomy, but after the atherectomy passes, the wire falls back down the channel nice and easily because we've created one. And just checking, this is obviously always the worry with atherectomy, there's been some embolus into the perineal artery. But if we look on IVUS about what's happened in that SFA segment, we see that we've cleared a channel through the soft plaque with the atherectomy, but a lot of these nodular calcium lumps are still there. Now, obviously, we don't want to spend, it's difficult to justify spending a lot of money on every case, but I felt that stenting here would be a problem. This guy has told me that he still continues to smoke, and he intends to continue to smoke, and we know that smoking and stents doesn't really work well together. The runoff is a little bit impaired because some embolus has gone into the perineal. It's probably okay, but I wouldn't bet on that stent staying open for a very long time, particularly if he continues to smoke. So at this point, we made the decision to open a second vessel prep device and use IVL to treat that calcium. And we had a good result there. And plain balloon angioplasty, drug-coated balloon angioplasty out to size, and now this is the IVUS again. Much better, apart from in one location there was an area where you can see it's not completely perfect, but there is one particular area where we can see significant stenosis. So we went back and hit that again with a high-pressure balloon angioplasty at that location. Again, aiming in our mind here all the time to try and get as good lumen as we can, but avoiding placing a stent if possible. And after the high pressure balloon angioplasty, we had a much better result with just this small area of like a little focal perforation, like a pseudoaneurysm you can say there, but it was looking stable. Over time, we just inflated a balloon at low pressure across that to help it seal up. And that's our final angiographic result here. Just coming back as we check. The initial duplex about 6 weeks after the procedure showed that that perineal has come back to life with a little bit of heparin overnight. The iliac stents are nice and open, and the SFA pop segment is nice and open. And then we saw him in clinic several months later. His rest pain had got a lot better. The ulcers had almost improved. But all these cases, you have to ask yourself, is it worth spending so much money up front? You know, an atherectomy device, an IVL catheter. Well, this case I did in December 2022, and we saw him in clinic back last month with some new sort of leg pain, maybe referred as claudication, worse on the right side. But actually, his ABI on the left is still 1 with a normal response to exercise. And when we checked it on duplex, iliacs and left SFA still patent, 3-vessel runoff, sort of 55% stenosis in the proximal left SFA and a little bit of stenosis in the ATA. That pseudoaneurysm is still there but partially thrombosed. And in the end, it feels like his symptoms are more spinal because that revascularization in very tricky calcified arteries threw a lot of money at it at the time, and it stayed open now for 2 years and still going. So these are the kind of results you can achieve with good choice of vessel prep devices in selected patients. I'm certainly not doing this in every patient, but you're choosing the patients where spending that extra money up front is going to buy you longer term results. And happily he has now quit smoking, which is also good. Cool. That's it from me. Any questions about calcium? Conrad. Oh yeah, mics.
Could you just go through your reverberation?
Reverb, yeah.
How that implies improved?
So reverb at the moment is very much a qualitative thing, right? It's difficult it's not something you can measure currently. Let me get the picture up to show you what I mean. But I don't have the reference with me now, but I'll find the paper while we're sitting. There is a paper that has shown after atherectomy that you get an increase in the amount of reverb and the change in the pattern of the reverb, which we think means that not just because IVUS from the inside you can only see the inner layer of calcium, but the reverb is what tells you what's happening about the calcium behind that very much outer layer, and it shows that after atherectomy there's a change and an increase in the amount of reverberation. So something has happened to that calcium behind that the ultrasound waves are bouncing within it a little bit more and then coming back to your transducer a bit later on. It is qualitative at the moment, so I wouldn't. I don't know. I'm not sure if elastography in this setting of heavy calcium is really discerning enough. Again, we're looking for things here that are easy to measure or easy to appreciate and are actually going to change our decision making. So reverb at the moment we don't really have it. It's just telling us that something is happening rather than being something that we use to guide treatment or say that this is enough or we've done enough here. Yeah, you do. Yeah,
That's nice. It's a nice addition.
yeah. So that's the loop where you see the reverb behind. So for example, here, 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 there. Again, this is qualitative. This is just we're trying to get as much information as we can about what's happening to the artery without the ability to hold it in a hand and roll it in a hand and feel what's happening with the calcium. And these are all just little clues that we can tell. Again, it's not enough to guide what we're going to do, but it's telling you that something more is happening just than on what the layer that you can appreciate on the intima.
Do you have any other questions?
One over here, Tom.
Thanks. I was wondering, have you got a selection of different atherectomy devices available? And if so, does anything on your IVUS imaging help direct which one you're going to choose?
Yeah, so we have Phoenix and Jetstream. We are comparing our institutional experience with both to kind of try and understand which ones work best in which scenarios. I kind of, at the moment, have a sort of phenotype of patient that we use to choose one. So that I find the Phoenix particularly useful in young females, often recent or continuing smokers with small SFAs. Not calcified plaque, but like fibrous plaque and small vessels. I find the 2.2 Phoenix really, really nice for those. And that's a large, quite a big cohort of patients, right? They'll have a long SFA occlusion, small vessels, and if you can cross intraluminally, atherectomy, DCB, nice result, avoiding stenting in small vessels. The Jetstream I tend to use much less, actually. Probably the ratio is about 3:1. I don't do a huge amount of atherectomy. I certainly don't do as much as many of colleagues in here who work in Germany will do. But I personally probably do about 10 to 15 cases a year. And about a 3:1 ratio of Phoenix to Jetstream. Jetstream is for the much larger vessels, heavier calcium. IVL is eating into some of that business now for sure, but that's again where IVUS will help me decide what's the anatomy of the CTO. Again, there's another phenotype that you'll all recognize, which is a 20 centimeter CTO, which is mostly soft plaque, and then there's just 1-inch segment of calcification in the adductor canal, which was the culprit lesion that started off as a heavily calcified stenosis and has turned into the CTO. So with the appreciation of that on IVUS, I can say, well, actually, we don't need to necessarily atherectomize the whole thing. We could just use IVL on that single bit and then plain balloon angioplasty the rest. If we see long, heavily calcified CTOs with multiple segments of calcium, where we know that maybe the IVL catheter, we might need to open 2 IVL catheters, et cetera, things might spiral a little bit from the cost point of view, then I might reach for the Jetstream instead. But again, that decision would be based on a risk of embolus if the patient is particularly sensitive clinically to an embolization event, or if it looks like it might be very difficult to fix an embolization event, then I might lean towards IVL versus Jetstream. So the decision making is quite nuanced, but we're looking back through our institutional experience at the moment to try and see if what we think, if we think the choices that we're making are correct and leading to improved outcomes.
So, NT, on the note of atherectomy versus IVL, I notice you use IVUS a bit differently. So you might use IVUS to measure stenosis during an atherectomy case, and you might use IVUS to look at area and lumen gain during a IVL case. Can you explain the subtleties there?
Yeah, I think with atherectomy and IVL, it's an option of how it's going to change your decision making. So any atherectomy device, once you've run it, unless it's directional atherectomy, which I don't really use because in my hands maybe I find it not as effective and with much higher risk of distal embolization and just fiddly to use. You have to keep taking the device out and cleaning and with the filter, et cetera, et cetera. So I'm not a big fan of directional atherectomy, first thing. So put that to the side and say that we just use rotational Phoenix or Jetstream. once you've gone through the lesion once or twice with the atherectomy catheter, there's not really much else you can throw at it, right? From the modification side. Jetstream, you can do your pass with blades down, blades up. Again, with Phoenix, you can go through a lesion. But once you've been through it twice, there's nothing else you can do with it because you've made that channel. Whereas with the IVL, you have a little bit more of an option to kind of see. And if you need to use more cycles on a particular area, for example, if you can see that there's one nodular plaque of calcium that we don't see those fractures in, then you say, okay, well, maybe I'm going to take the balloon back there and deliver more energy at that specific point. I think with IVL, because you get that kind of 360-degree calcium cracking in the media, I see this phenomenon of the media and relaxing and the vessel opening out in size more often in IVL than we do in atherectomy again. So that's where I find it useful in terms of DCB size. So yeah, that's pretty much the information that we get. We're always looking for something that's going to change our next step or change a decision making that we make at the next step, whether it's more IVL, different size DCB, need for bailout stenting, if we can see on the IVUS that there's been a deep dissection going into the media.
That's okay. So I was going to ask, thanks, Enti. I was going to ask you a quick question about what you said about multiple technologies. We have exactly the same challenges as well, of course, and it is that decision that we sit, I think, somewhat uneasily about the amount of money sometimes that I'm throwing at one case, particularly in the cohort of patients that may not live beyond 6 to 12 months anyway. But my question for you is, I mean, I know our experience in the Royal Free, we're just up the road from St Thomas's, is that we don't come under a huge amount of cost pressure from others. I think certainly, and I don't know if my colleagues here would agree with me, we do have some questions, don't we, sometimes from maybe our open surgical colleagues about the money we spend, which we can justify. But I just wondered whether that's a challenge in your unit at all from some of the non-believers.
Yeah, I think this is always a very country-specific discussion, right? How the specific model of reimbursement drives your practice. Again, I can't remember who's talking this about. In an ideal world, you would have a paradigm of this is what good clinical practice is, based by evidence, and this is how you should choose devices, this is how you should use expensive devices in the most effective way. And then whatever the pattern of reimbursement is in your country should encourage you to aim towards that standard of good practice. Unfortunately, that's not the case everywhere in the world. Some places you have very definitely reimbursement drives your practice because certain devices are much better reimbursed than others that may be equally as effective or are almost as effective but a lot cheaper. In other countries, like for example in the UK, you might get paid a certain bundle per patient, and you get paid that same bundle whether you stick 2 plain tibial balloons down and do a quick angioplasty for £80 worth of kit, or whether you do the atherectomy plus IVL extravaganza with a VBX stent and two Zilvers and et cetera, and you get the same amount of money for that patient because they've come to you with CLTI, they've stayed for 2 nights in hospital, and this is what you're going to get paid. So, yeah, very country-specific discussion. I think what we don't appreciate is how much ongoing wound care, recurrent visits to hospital from the community costs the health service as a whole. And again, in the UK, we're a bit limited that healthcare and social care, even though they're a little bit more together, now come from different budgets. So the cheapest thing for a hospital to do is to do a below-knee amputation, because as soon as the wound's healed and knitted, the skin is a bit knitted together, you can get them out of the hospital very quickly, and then somebody else is paying for all the rehab. Whereas actually, if you look at the health for the country as a whole, the better thing is to get people walking, so they don't need an expensive prosthesis, don't spend a month in an amputation rehab unit learning how to walk on their prosthesis, and actually the cost of a £1,800 catheter pales into significance at that end cost. So it's very country specific.
Totally agree with you, and I think this is a discussion that we've had many times when talking to people about where IVUS fits in and how we can justify it in terms of the overall cost to society. And that's true whatever country you're in. So I guess the question I'd have for the audience is how many of you have actually had difficulties with obtaining IVUS in your practice, and how have you managed to do it, to justify it? So one of the ways that, just like NT has said, we've done it is from our publicly funded health system, we're actually able to have a more sort of hospital-based overview in order to say that by transferring people to 23-hour stay or day case type surgeries, we're saving on high dependency beds, on inpatient stay, and we obtain the cost back for the device through other savings elsewhere in the hospital. But I just wondered what everyone else's experience was.
In Germany, IVUS not yet reimbursed, but I hear that that may change soon. So is there anything that people may feel that, okay, well, this specific high-risk case, it's going to give me some information that even without the reimbursement, I'm going to open it? You know, I would argue that the complex lesions in critical limb ischemia patients with advanced wounds, these are going to be expensive patients anyway, and you want to be sure that you're opening the right expensive devices that are going to be the right treatment for them, and that's probably where the cost saving will be more realized.
Is that how it works for you? Is that the issue you have, or do you have a situation where you have to, per unit, justify the cost of each procedure?
So the thing is, in Germany, it's partly decentralized. It's not like the NHS, so you have to do it on a hospital-to-hospital basis. The thing is, what worked for us? You have to go into you have to with the hospital with the administration. You have to start haggling, more or less. So the way it works is that you can the argument we used was that it's an option without an alternative. So there's no other device that does this, and this works for this and these reasons, because there are already some publications. The way we did it with IVL too, because IVL is also only 50 or 60% reimbursed. Yep. It's not completely reimbursed. So we're at a loss for every case we use IVL. But that's with the argument that there's no alternative option. It's a new device, no alternative option. This is the data. It usually goes through.
No, it's a difficult one, and convincing hospital management is not easy because they often don't have they're looking after their particular budget, and if the money is spent elsewhere, they don't care. They just want their little slice of that budget to be nice and under control. Conrad.
About IVL, just one last bit. So someone wrote a consensus paper, and there's a it's a very good paper, and I think it helps give guidance on minimum 60 pulses, etc. The post dilatation, post IVL, that decision, sometimes I don't think you need it. I think sometimes actually the balloon device, not balloon angioplasty, has done enough work. Would you ever change that decision whether you post-treat based on an IVUS image, or what's your feeling?
I think it depends very much on the morphology of the calcium. So, you know, if you've got circumferential calcium, I would need a very good reason not to post-dilate. Yeah. However, there are certain lesions where, particularly now as we're doing more iliac IVL with the larger devices, you can see those calcified plaques that are almost grabbing together two bits of the artery and kind of holding them together with a little calcified clip. And as soon as you IVL those, it just pops off and the vessel opens out. And in those cases, maybe you don't need to do a plain balloon angioplasty. So yeah, that may be, but almost always I will post dilate out to, if not the true vessel size as measured by IVUS, very close to it, and then a DCB to the correct size at low pressure. So I need a really good reason not to post dilate.
And do you think that's the same for tibials? Because obviously with the E8, we've had a few cases where there's this sort of medial calcification, and the vessel is just a bit smaller than the native, healthy vessel above, but there's no true stenosis. Do you still post-dilate those?
Yeah, I still do. And again, with tibials, long balloons, try and make sure that we're going from healthy to healthy as much as possible. I think, that for me, that's what vessel preparation is, that you're preparing it for a plain balloon angioplasty, and you can feel empowered to do that plain angioplasty balloon out to the true size of the vessel because you've modified the calcium already, and you're not going to get all those complications that we talked about on the first slide in terms of dissection and perforation, etc. So yeah, I need a really good reason not not to post-dilate out to size or close to size. Oh, definitely smaller, yeah, because by definition, you should have oversized the IVL balloon by at least, 10% at least. So yeah, your post-dilation will be smaller than that. And though sometimes, as said with that tibial case that I showed you, even just after post-dilating to 3 millimeters, it's those little cuffs of calcium have been thrown off and the vessel opened out to close to 4. I didn't balloon it to 4, but once the calcium has been changed and it just pushed out a little bit, it opened to that.
I was going to say that I think that's where IVUS uniquely can guide your decision making on a lesion by lesion, on a vessel by vessel, and on a patient by patient basis, doesn't it? Because I've certainly myself used it as a way of avoiding what I thought was an inevitable stent, for instance. I mean, certainly the tibials being slightly different with a lot of the medial calcification. See, I'm inclined there, if I get good lumen gain as visualized on the IVUS, to not post-dilate, purely to avoid the risk of a dissection at that point. But it's the IVUS that's guiding that. But likewise, rather than the angiography, but likewise, certainly up in the iliacs, in even the aorta, if I've got the lumen gain that we were intending, actually that's changed my decision, and I've then gone on to make the decision not to stent on the basis of the lumen gain I see on the IVUS.
On the IVUS. But then again, there's another feed into that decision making, right? Which is that plain balloon angioplasty in a heavily calcified iliac is definitely more sphincter clenching than in the SFA, right? So if you can get that confidence on IVUS that actually we've dealt with the calcium, we've got good enough lumen gain, and now we've got the confidence to avoid a step which brings with it significantly more risk than post-dilating in the tibials or the SFA.
Yeah, no, I totally agree. But these are the sort of things that I think you can claim some of the cost of the IVUS back because of your avoiding of the stent, isn't it? Because you've assessed it properly, and instead then to go ahead and what we would have thought would have required vessel prep then stent, I've justified the cost of the IVUS again by saying, all right, I've just saved myself the VBX cost.
It's all relative.
Exactly, yeah.
Cool. All right. If that's everything, I'm going to hand over now to Professor Korosoglu. Hi, Prof. So Prof. Korosoglu, everyone will know his name from Weinheim. He's done a lot of a huge amount of atherectomy and has a huge amount of experience in this area, probably more than many of us will ever achieve in our lifetime can put together. And he's going to speak on that topic for us and share some insights.
Hello together. Thank you for the nice introduction. And I heard you had a nice discussion about IVUS. I'm also a fan of IVUS, so I hope you can hear me clearly and you can see the slides. Okay, so now we transfer a little bit to another issue, which is lesion preparation and atherectomy, especially here using the Phoenix atherectomy device. And what are the theoretical consideration with atherectomy? Basically there are 3 types of revascularization, or the 3 types to treat a lesion. Of course, you can bypass a lesion by doing open repair. Secondly, you can do conventional angioplasty and then squeeze the lesion apart to the vessel wall and then put stents inside. And what we prefer actually in selected lesions, especially in the femoral-popliteal segment and in moving segments like the common femoral artery and the popliteal artery, is to do lesion debulking, lesion preparation, for example with atherectomy, in order to be able to avoid stents in these regions. So with atherectomy, basically we can preserve the compliance of the vessel. We can increase lumen gain without barotrauma. And we know that we cause less dissections than with conventional angioplasty. And by this way, we also facilitate more leakage of the drug elution into the vessel wall, thus enhancing the antirestenotic effects of this sort of treatment. We all know that atherectomy is rising. The numbers of atherectomy being performed in the US are continuously rising. So one should ask himself or herself, is there evidence for that? do we have real evidence for in terms of LCT that lesion preparation or that the patient profits from lesion preparation? And we have the Cochrane meta-analysis, which is not so current. It has been published a couple of years ago, but here we could clearly prove that with atherectomy, you cause less barotrauma to the vessel, you inflate with less pressures, we are causing less dissections to the vessel wall, and we have a significantly less amount of stents that have to be implanted, which is not only significant but also substantial. It's like 26% of in terms of rate of stent implantation compared to lesions that have not been prepared by atherectomy. On the other hand, the RCTs show no clear advantage in terms of vessel patency, target lesion revascularization, and amputation rate. This was also confirmed in a recent systematic review and meta-analysis from the London group. The colleagues here also showed that the stent rate goes down. Again, 1/4 of the stents, hazard ratio is 0.25, but TLR rates are not influenced by atherectomy. So here I think there is room for improvement and for future studies in this field. We also summarized the advantages and disadvantages of atherectomy in this expert opinion paper. And here again, you can see less stents, similar rates of complications, but no differences in terms of target lesion revascularization, patency rate, and amputation rates. So I think the solution to that is atherectomy is not indicated for every lesion in the femoropopliteal segment, but for selected lesions. And here you can see that despite the fact that we don't have so good evidence for atherectomy, if you ask experts from different disciplines, so in this paper we had cardiologists, angiologists, radiologists, and also endovascular surgeons. And despite the lack of evidence, you get a high rate of agreement and also a high rate of strong recommendation for the use of atherectomy. But as I already said, not in every lesion, but in selected lesions. So we'll have to discuss which are the selected lesions we should perform atherectomy. And as you can see by expert opinion, it's the mobile segments, like for example, the popliteal segment, where you would like to avoid stenting, and especially lesions that are strongly calcified and where you can pass with a wire by an intraluminal way. Of course, we all know that with almost all atherectomy systems, atherectomy is contraindicated, so there is also a strong warning by the experts in case we pass the guide wire subintimal through the lesion. So in order to summarize the first part, where should we perform atherectomy? So rather in lesions that are moderately to strongly calcified and where the wire can be passed either by antegrade or by retrograde recanalization in an intraluminal way, and especially in younger patients where with claudications, where we would like to avoid a lifetime stent placement because these patients are going to live for a long duration, and especially in lesions like the popliteal artery, which are mobile segments. Another indication may also be endovascular failure. So these are regions where we have already put a stent and we have stent failures in the mid or in the long term. So the Phoenix atherectomy system is especially a system that combines rotational and directional properties of the atherectomy procedure. As you can see here, it comes in several sizes, which enables the treatment from the foot to the groin, and sometimes also in iliac arteries, but in most of the cases, let's stick to the groin and in the infrainguinal lesions. And you can see also that it is compatible with several sheath sizes. So if you have a small sheath inside and you do a BTK revascularization, you can stick with a 4 French sheath, and of course you need larger sheaths with the larger sizes of the catheter. This is like a demonstration. So here you can see it's a standalone procedure. You don't need a console to do the Phoenix atherectomy, which means you do not need a capital investment in order to start with such procedure. And here you can see an overview of the papers of our group. I would like to stick to the main paper we published a couple of years ago. And this was an analysis which was conducted in almost in 402 consecutive patients. And it's really important to mention that all of these patients had task C or D lesions and moderately to strongly calcified lesions. Here you can see an overview of the characteristics. So this is like the typical PAD cohort. Again, 1/3 about patients with lifestyle-limiting claudication, 2/3 with critical limb-threatening ischemia, and lots of femoral-popliteal lesions, but also lots of BTK lesions available with this cohort. Here you can see the distribution of the atherectomy catheter sizes. So, as expected, larger lumen atherectomy catheters with larger lumen vessels. And here is an overview of the success rates, which was very good. Procedural success rate 99%. And also it's very important to say that, to mention that also the complication rates were quite low. Vessel perforation 1% of the cases, and in 2 of the cases we had to cover the perforated segments with covered stents, and we had 2% of distal embolization. Another thing that's important to mention, that despite the fact that the lesions were strongly calcified, we had a stent rate of 16% with femoral-popliteal lesions. Here are the target lesion revascularization rates over time. Again, a limitation, we do not have patency rates. We did not perform duplex on regular time intervals, but we have the TLR ratios. And as expected, you can see poorer or higher TLR ratios in patients with longer lesions. But at the end of the day, we see that 90% of the patients had profited clinically from this procedure. So 59% of the patients had a reduction in terms of Rutherford category, and 10% of the patients with CLI had also such improvements. Of course, again, we have to mention it's not just the atherectomy that did this difference. It's, let's say, the atherectomy-assisted endovascular treatment. As I already mentioned, we also focused on selected lesions. So these are segments where you would like to avoid stent placement. On the one hand, it is the popliteal artery where you have a very moving segment. So here you would like to avoid a stent due to fracture issues and also stent failure issues. On the other hand, we know that the common femoral artery is not a mobile segment, but still we would like to avoid stenting in this segment due to the fact that it's a segment for further access, for example, coronary interventions, TAVI, or other sort of interventions. And it's also a bypass anastomosis zone, exactly as the popliteal artery. Here we had the experience, we studied several grades of complexity for such lesions in the common femoral artery. And after all, we saw that in not so complex lesions, so lesions that are not so strongly calcified, do not enter into the bifurcation of the femoral segment, we have very nice TLR rates. So here we have a surgery-like result with less complex calcified lesions. Again, if we take a look at the very, very severe, very calcified lesions that involve the bifurcation, here perhaps it is an issue. So we have a TLR a freedom from TLR of 60% at 3 to 4 years. So here we are not so good as open repair. Another subsection analysis for the popliteal artery. Here you can see for the common femoral and for the popliteal artery. For the common femoral artery, you see, we would like to do the best for the patient, so we combined this treatment with atherectomy, in many cases scoring balloon angioplasty, and then also in almost all cases drug-coated balloons, and by that we could achieve a stent placement rate of just 3%. In the popliteal artery, you see less scoring balloons, but again, a high rate of drug-coated balloons, and again, a quite low stent placement rate of about 6%. Here are the ankle brachial index values before and after the intervention in the common femoral on the left hand, on the popliteal artery on the right hand. And here are the Kaplan-Meier curves for the CDTLR rates and for a breakdown between patients with claudication and CLTI. But much more interesting is the fact that we also did a retrospective analysis from an Italian cohort, which was treated by DCB in the popliteal artery, but without atherectomy. So the blue one are the lesions that were treated with atherectomy and DCB, just again for the popliteal artery, and the red ones are the ones treated with DCB but without atherectomy. And here, indeed, for this selected segment, and again by retrospective analysis, so this was not an RCT, but still you can see a good success in terms of reduction in CDTLR rates if you use atherectomy on top to the other sorts of treatment that we'd use with the popliteal artery. For in this case, it was balloon angioplasty and drug-coated balloons. Last but not least, some case examples for the popliteal artery. Here you can see a lady that came to us 6 years ago with lifestyle-limiting claudication. We did atherectomy and DCB for her popliteal artery. She came back 5 years later with a similar lesion. But to make the point, even if you have failure of this procedure, we can again do atherectomy and achieve a good result. And of course, it's important also to have these patients at follow-up and at close surveillance by the angiologist or by the cardiologist or vascular surgeon. Here is an example of the common femoral artery. You can see here a 6 French sheath, the injection of the contrast medium in the common femoral artery in a very strongly calcified lesion of the groin. Here you can see again, we did not exchange the sheath. We stayed with a 6 French sheath and a 6 French deflecting atherectomy catheter. So this system gives you the flexibility. Since you have lots of devices, lots of sizes, you do not need to exchange the sheaths. You also do not need a filter for protection, which makes, of course, the whole procedure much more cost-effective and also faster. And remarkably in this case, of course, we show representative cases which are also nice to appreciate by visual inspection. But you can see in this case that only by atherectomy you can appreciate a very nice lumen gain in the common femoral artery. So again, this is the angiography after the atherectomy procedure and without balloon angioplasty. So you can see a lumen gain, probably a reduction from a 90% stenosis to like something like a 30% stenosis, residual stenosis. And on the right hand again, you can see the final result after atherectomy and drug-coated balloon angioplasty in this patient. I think you also had some nice IVUS examples which have already been demonstrated. Here is a demonstration of the use of atherectomy for a BTK vessel balloon angioplasty. In that case, it is an endovascular treatment of the anterior tibial artery. So here you can see again the puncture from retrograde and the intraluminal guide wire passage from retrograde, then a wire externalization, and then we performed atherectomy by the 5 French or the 1.8 tracking device. Here you can see the result by the IVUS after the atherectomy and the angioplasty. After the angioplasty, you can probably appreciate the mobilization of some thrombus within the vessel. You can see it here, some floating components and thrombus. So in that case, we also performed guiding aspiration in this lesion, and this was the final result with a patent anterior tibial artery with a good reflow. Last but not least, this is an example which demonstrates also that the Phoenix atherectomy device can also do very well in very distal lesions. Here you can see again an occlusion of all the 3 foot arteries. Both the anterior tibial and the posterior tibial are occluded. You can see a peroneal artery, but which is not enough in order to supply, to sustain the blood flow to the foot. That's why the patient presented with a gangrene. And here in this image, you can see that you could go quite far with the atherectomy catheter. In that case, it was a 1.5 tracking catheter, which can again also be inserted using a 4th French sheath. And here you can see the final result in this patient. It's a patent anterior tibial artery. We combined the atherectomy procedure with POBA in that case, with inflation with a 2.5 balloon and a 2.0 balloon at the distal part of the artery, and with a good clinical result. So thank you for your attention, and I'm happy to get your questions now.
Do we have any questions at all from the audience? Yeah. Great, that was a wonderful talk. Thank you very much. There's some questions from the audience.
Prof, can we ask, do you mandatedly use a filter with your atherectomy? Always? Thanks.
Sure. Yes, thank you for the question. So this depends on the type of atherectomy, device. So it's not a yes or no answer. Our experience with the Phoenix atherectomy devices, we never use filters actually. I've never used filter with the Phoenix atherectomy device. Of course, the embolization rate is not 0. You have embolizations. In our registry, it was 2%. So in case, this is perhaps an important message for the group, in case you do atherectomy, independent of the type of atherectomy you're using, you also need to have the tools for addressing such complications. So you need to have a guiding catheter. You can aspire. We can do catheter aspiration, manual aspiration. Optimally, because these catheters are not very long. So if you are going crossover, you might get difficulties. You may not be able to get so deep into the lesion. So in that case, you either need to perform an additional antegrad puncture in order to do manual aspiration, or you need to have thrombectomy devices in your lab in order to address these complications. For example, a Rotarex catheter for bigger vessels or a penumbra device for smaller vessels.
So I'd second Greg on that. So we never use filters with Phoenix atherectomy, apart from those sort of subacute lesions. So even for the atherectomy, we won't use a filter, but for the angioplasty after, we might pop a little filter down, because it's the angioplasty where you get the trash rather than the atherectomy itself.
Yes. Yes.
Greg, can I ask you a question about atherectomy itself? So obviously there's a 2.2, 2.4, 2.2, and the 1.8. And then there's a directional, the directed. When do you decide on the 2.4, and when do you decide on the 2.2? It's not purely on the size, is it? Because you used the 2.2 for the common femoral earlier.
Yes.
So how do you decide on the...
Right. That's a very good question. Actually, For the common femoral artery and for big SFA and big popliteal arteries, I always prefer the 2.4. There are, of course, some patients that, as the one patient that I showed, you may have small vessels, you may not be so comfortable with the 7 French sheath. So then an alternative is the deflecting 6 French, so a 2.2 with deflection. It's a good alternative, but as you exactly know, the 2.4 allows you to do more debulking, the 2.4 deflecting, because you can deflect yourself and adjust it to the lesion and to the vessel size. So with the 2.4, you get better and more extensive debulking. So in big vessels, like the common femoral, I always prefer to use the 2.4. Of course, there are some downsides. So if this is a CTO and you are not exactly sure, have I been intraluminally, have I been partially subintimally, you may want to use a device that is a little more low profile in order to avoid perforations.
Questions? I mean, you have a world expert here in Greg, so he has done the most atherectomy cases probably. So, yeah.
Hello, Professor Kosarglu. If you have to stent the pulmonary vessels, you did atherectomy with different devices, you did POPA, and you still have a significant stenosis, and you see it without stenting won't be good. So which stent type would you use? Covered, uncovered, balloon-mounted, self-expandable?
You mean in the FemPop segment or?
Tibials.
In the FemPop segment, yeah.
No, in the tibials, in the tibials.
And the tibials, in the tibial vessels. Yes, in the tibial vessels, we always prefer drug-coated stents, drug-eluting stents, in the proximal and the mid segments of the tibial vessels.
So, I mean, all we have right now is the ones that balloon-mounted designs is what we use. So.
You know, the downside is, of course, we do not have very long stents. So the longest drug-eluting stent we have is from the coronars is 4.8 centimeters, is 48 millimeters. So in case you have, it depends why you have to stent. If it's recoil, I would rather recommend a drug-eluting stent. If it's just dissections, then I think that the TAC device is also a very good solution in order to fix the dissections in the tibial arteries.
I think that's an important distinction to make, isn't it? Understanding what's recoil, what's residual stenosis, and what is a dissection. And for me, that's where IVUS really helps give you that insight, because each one of those is managed in a different way. And spasm as a fourth one is something that can give that. So all these 4 things can look exactly the same on an angiogram, but they all 4 have a very different way of managing them. So trying to differentiate between those is pretty much the challenge in treating tibial disease.
And as you already mentioned, I know you are a big fan of IVUS, and as you excellently already mentioned, in these cases you need an IVUS to differentiate between a thrombus or a recoil or a severe dissection. Unfortunately, we do not have reimbursement for IVUS in Germany yet. It has been rejected for 2025, but we hope for improvement next year in this respect.
So we have 2 more minutes, Greg. How about for in-stent stenosis or in-stent occlusions? Do you use atherectomy for those, for the Phoenix for those?
Yes. This is also, I think, a very good indication for atherectomy, especially in bigger stents. So the risk of perforation is like 0 in the stent. So I think this is also a very good indication for the deflecting devices. We also never so far, I need to say, for in-stent, perhaps we don't have so much experience with the Phoenix device. Perhaps we have something like 50 cases. I think we have also never published that so far, but this could be also a thing for a multi-center study we could do together, probably. But we never faced a problem with getting stuck within the stent strut. So this is also, I think, a very good indication for big stents to do extensive atherectomy to get more lumen drainage.
Iliacs? Do you have any? Have you used it for the external iliac or the common iliac?
We have some very, very limited experience, but my personal opinion is I think that the devices that we currently have for atherectomy are not really appropriate for the big iliac vessels.
Okay. Any other questions? Well, thank you very much. That was fascinating and great to have
Happy
you.
to join you.
Thank you very much.
Next time, I hope I can be in person there.
Yeah,
But
that'd be great. Thank you very much, Greg. Take care.
Have a nice day. Bye bye.
So I think we're going to take a coffee
We have a
break
coffee
now.
break now.
Half an hour.
Yeah, half an hour coffee break, and then we have a test Mendy afterwards. So.
We still can't hear you. DCBs. So that's my idea. I will just show you a case with laser and IVUS where there was a good combination of these two instruments and devices. Next slide, please. So it's a patient, it's a 75-year-old lady. She's got hyperlipidemia, ongoing nicotine abuse. Unfortunately, she's in AF, several embolic happenings, both legs, and apoplectic insult in the history. And acutely, there's an instant, actually, a re-occlusion of the popliteal regions. Right side, but left side as well. Rutherford 3 still. Atherectomy of the left popliteal area was followed by PTA and drug-eluting technology plus stenting, mid-SFA left side in August last year, and then rotational atherectomy with the Rotarex device, 8 French, of the right popliteal artery, followed by 4 DCBs and placement of an interwoven stent supera because of dissection. That was in July 2024. And in the past history and other hospitals, they performed open thrombectomies twice of both popliteal regions. Thank you. Next slide, please. So what do I have beforehand? I've got a duplex ultrasound, which revealed the occlusion of the popliteal region and the BTK region, and an MRI scan confirmed these results. Next slide, please. That's the MRI. I hope you can just see what's happened. So both areas, the whole popliteal region is occluded. There's quite a bit of collaterals can be seen, 2 vessel runoff both sides, and a very, very uneven, not smooth vessel wall all through the vessels, which we can see here. Next slide, please. So my idea was a pre-intervention assessment because it was a re-occlusion, vessel preparation and treatment, and a post-intervention assessment and optimization. Next slide. So that's the angio. I had an integrated approach. Yeah, it's a bit more delicate than the crossover approach, but I think if I want to work below the knee as well, I prefer the integrated approach. You can see the vessel wall is very uneven, so lots of plaque material. Then the occlusion from P1 segment down to the P3 segment. And now to be seen in the angio, there's only an tibial posterior artery which reaches the foot and is obviously feeding the foot. Next slide, please. So that's the IVUS run. Yeah, can. Yeah, that's good. Okay, so I started below the knee in the tibial posterior. You can see now we are in the popliteal region. There's plaque material. That's a lot of thrombus that can be seen. It's very fluffy material, which is not that dense. And here we are in the stent, the interwoven superior stent, and which is ongoing here. It's all thrombus material and some plaque. And then we reach still thrombotic occluded, the P1 segment where the stent has already finished. So there is just the vessel wall to be seen. Okay, thanks. And the next slide, please. So that's now the followed by the laser, the post-intervention. As you can see on the right-hand side, the picture, there's a complete occlusion. And then after the laser treatment, that's on the left side, the picture, there's still a bit of material to be seen, but there's a runoff now, and the runoff now reaches actually the tibial trunk. As you can see with the Berenstein catheter in the middle portion, there's a Berenstein catheter which showed where which vessel are to be seen. Next slide, please. Now here, that was, yeah. So now there's the, probably you can show the, yeah, the IVUS run. So you can see the open vessel. There's already some pulsation to be seen. So we're in the below the knee vessel and still some thrombotic material here seen, especially down below. Now we are in the stent, which is opened up, but there's still some thrombotic material. And now it reaches the nature vessel. So there's still some thrombus. So here it's all clear. There's hardly any thrombotic material left. Okay, next slide, please. So we did another run with a laser with the high fluency and repetition. Unfortunately, we don't have an IVUS run for this, but this is now the final angio, because we could see there was an intimal flap just at the start of the superior stent, just above it. And so we prolonged. You can see here on the left-hand side, you can see the interwoven stent, which is then prolonged with the superior 5.5 to 80. And then the final result after DCB treatment, 2 vessel runoff with the perineal and the tibial posterior artery. Next slide, please. So that's the final IVUS run. As you can see, we are in the BTK vessels. You can see the both veins here, which are seen next to the artery. The vessel so far is clear. And there's a bit of stenosis still. And here's plaque material, but the thrombotic material is mostly gone. And finally, we reach again the stent. And now the stent material. And finally, yeah, so there's a bit of stent still to be seen. Yeah, next slide, please. So what happens when we do an angio? The problem is we never know really, because of the 2D dimensional imaging. We never know, is the guide wire position in the true lumen, or is it if I'm in subintimal space? So what is the true diameter of the vessel? Because I can, with the plaque material inside the vessel, I often measure it wrongly because I can't see the thickness of the vessel wall. And what is the plaque morphology? Is it calcified? Is it fibrotic, fatty, or is it intimal occlusion? Is it plaque eccentric or concentric? So the vessel is just seen with the different camera angles, which provide us with the X-ray view A and B. So that's all what we can reach. So the percentage stenosis in the X-ray view A is definitely lower than X-ray view B. So this lack of precise information makes us uncertain how to treat the vessel. Next slide, please. And so, like, for example, what do we have here? Is that a dissection? Is that a calcium? Is that a thrombus? So if you see all these IVUS images, you can define this. You can really find out, is there a flap just in the vessel wall, occluding my vessel? Is there a dissection? Do I have calcium which can be treated? Is there thrombus material? So do I have to do another run with my laser or Phoenix device? So all this can be modified and clarified with the IVUS. Next slide, please. So what's happening with the laser and DCB study-wise? What we can find is after 6 and 12 months after laser and DCB treatment, you have a higher patency rate after these months. And if you have the DCB only, it's much lower. It's actually between 8 versus 46%. And so this is really showing how important it is to do an atherectomy before the DCB or stent treatment. Next slide, please. So what does the laser actually do? I think I like it because it's quite an easy use, although the capital equipment is quite expensive, but it can treat neointimal hyperplasia. It can treat thrombus, what we just have seen with my patient. It can treat lipid and fibrotic plaque material and fibrocalcific plaques and focal luminocalcium crystals. What it can't do really is really hard calcium. But I found out in the iliacs, which is off-label use, if I had really hard calcified plaques in the common iliacs and couldn't pass with the EVA device because of 16 or 20 French, it's quite similar to lithioplasty because of the cavitation bubble. You can disrupt the calcium and then dilate with the balloon and pass as well with the EVA device. It's off-label use, but I think as well with young patients which are calcified, I still try to prevent stenting. Next slide, please. So what can IVUS do for us? IVUS shows a much higher degree of neointimal hyperplasia, and about 1 centimeter above the superior stent, intimal flap could be seen. And that was the main reason for the reocclusion in this case. Next slide, please. So, so this is my workflow. We had the MRI scan, and that showed non-sufficient imaging as well due to the nitinol stents in the popliteal regions. So, as we know, MRI can't give us an information here in this area because of the stent material. So then we had the 2D angio, and I could see the mixed morphology of intimal and thrombotic reocclusion starting 2 centimeters proximal of the stented region. So after lasing, I had a sufficient flow in the prior stented popliteal region, but very uneven vessel walls, so there was still material left. So I had to do another laser run. And what does IVUS do in this case? I could see the intimal flap, which I hadn't seen beforehand. So I prolonged the stent, and yeah, fortunately, so far the patient hasn't come back to me. So she's been seen in the outpatient clinic, and still the result is still open. So both BTK vessels are fed, and the foot is in good condition. Next slide, please. So reocclusion, it was a reocclusion, and that's why I did an IVUS before and after atherectomy. I used the laser atherectomy device, the 2.3 turbo power, which is rotating in the vessel, so I can get a much better lumen gain. And it has got the FDA approval, and it's the only device actually which has got the FDA approval, because as many people might do, I used the Hawk 1 as well, or the Avenger Pantheris, to do a clearing of the stents. Unfortunately for everybody, Avenger is broke, so insolvent. And so with the Hawk device, you don't have a visualization. So the actually best device in my hand at the moment is the laser atherectomy. After this, I always do an angioplasty with drug-coated technology, because as you know, you harm the intima. Either you do laser with the whatever, or the Hawk or the Phoenix. There is a repair mechanism, as we all know, which is ongoing for 6 to 10 weeks. So if we don't prevent the healing and scarring inside the vessel, you will have an early reocclusion. And if you know, everybody might know the definite AR study from the Professor Zeller, which is a long time ago, and was totally underpowered with like 48 patients. But that already showed you have to use that drug-coated technology, otherwise you have a very quick reocclusion. So here, second run with the IVUS, revealing a proximal intimal flap, and then we prolonged this with the superior stent. Next slide, please. So laser and IVUS. So the laser device is dedicated for soft tissue. So that's the main area where it can be used. Calcified plaque can only be altered in structure, but not removed. So it softens up. If it's like lithioplasty, if you use it, then the balloon afterwards opens up, not with the dog bone phenomenon, but just opens up very smoothly and with lower pressure. So the IVUS identifies for me the pre and post treatment, where especially in long lesions, was the amount of debiking sufficient? It wasn't here, so we used a laser for another run. IVUS might change the further treatment. Dissections to be stented, eccentric plaques leads to more, maybe directional atherectomy in a future run or treatment, and IVUS saves us a lot of radiation. Next slide, please. So in summary, IVUS led to identifying the most likely reason for the re-occlusion. It was an intimal flap. Obviously, the interwoven stent hadn't covered the complete area, being led only by the angiogram. And in 70% of the cases, IVUS diagnostics leads to a change or expansion of the endovascular treatment. Thank you.
Matthias, thank you very much. That was a fantastic talk. I think you can see the audience. We're going to ask for questions. You must have some burning questions about laser. JJ. There's another microphone somewhere. Yeah, go on.
So thanks for your wonderful talk.
We have a question from JJ, who's a consultant from Singapore.
Hi.
All right.
Thanks for your wonderful talk. I noticed on your initial IVUS runs after crossing that there was a short segment in the distal pop where it was subintimal. I don't know if I'm correct or not. The IVUS run played quite fast. But I noticed that after crossing, there was a short segment subintimal crossing over the P3 segment. So my question to you is laser atherectomy, can it be used for subintimal crossings? Is it safe?
Yeah, so far I use it because if I have long lesions, especially BTK, I never know if I'm really intraluminal unless I use IVUS all the time, which is not really possible in my workflow because of costs in Germany. It's not reimbursed peripherally, and as well, you're often in a rush or whatever. So I use IVUS really if I have a problem, and then it can be revealed. But if the laser is in the subintimal space, my patient tells me that I'm in the subintimal space because in Germany, I do it under local anesthesia, only in the groin where I puncture. So if I'm getting closer to the adventitia and to the nerves, the patient says just is in pain. So I usually then proceed, push it forward without lasing. And then if I'm in the intraluminal space, then I just proceed. So far, I've seen no paravations yet.
Thank you very much.
Any other questions? Matthias, I noticed that the debulking is a bit better or sort of more extensive than with, say, Phoenix atherectomy. Have you found that with the laser? Can you achieve a better sort of lumen debulking gain before angioplasty?
Yeah, so I just have, I think, because I use these two devices and still others, so I think I've got like 5 or 6 different atherectomy devices, and all of them do something different to me or to the patient. So the Phoenix device, for me, is very, very highly dedicated for calcium, which the laser doesn't. So the laser, for me, is soft tissue, intimal, like in-stent stenosis, thrombus, and that's my laser cases. And if I have highly calcified patients, I definitely use the Phoenix. So definitely it's much better then, because as I said, the laser wouldn't do a debiking; it would just change the structure, I think, of the organic tissue, which is still embedded in the calcium. So that probably that evaporates, and then it's if you dilate the calcium, it's much softer, but it's not gone. So that's definitely a case for calcium. Is definitely for Phoenix.
Is anyone here using laser at all? Anyone got experience with laser? We haven't at St Thomas's yet. So have you guys at Royal Free? How about capital equipment? So obviously the Phoenix is out of a box. It's so easy to use. You know, you can put them on the shelf. Do you have to have a lot of equipment, capital equipment, to use a laser?
Yeah, unfortunately, there is a quite big machinery coming with it. It's Yeah, it uses up a bit of space in your cath lab, so mine is very restricted at the moment still, but we found a corner to park it. It's the new laser is quite easy to put up, but the equipment itself, it's not cheap. So in Germany, it's about 160 or 180,000 euros, and as well, but you can have a leasing or whatever contract with Philips, and that's what I'm doing now. So we are leasing it, and then you can gain and reach at the end, you can buy it for less money. So that's how it works for me, because my hospital doesn't have the money at the moment.
So what would be your pearls of wisdom if for the audience here, if you're just beginning, starting off with vessel preparation, how would you go about it? Would you think about Phoenix first, or after all your experience, obviously laser and Phoenix have two different sort of benefits. How would you start your practice off if you're just beginning?
Yeah, so I think laser I would probably have later on, because I started my first atherectomy, I think, was more thrombus. That was Rotarex. My second device was Hawk, and my third device was then Phoenix and laser. So that was how I started. I think you need probably, if there's a lot of thrombus material or occluded bypass, I still use Rotarex. Total occlusion of a P3 bypass, 8 French Rotarex clears it off if it's really fresh. If it's like a bit older material, definitely the laser does a better job for me, because then the Rotarex will only cause or do a channel. But otherwise, because Phoenix does calcium. Secondly, probably I would use the Hawk to do soft tissue, intimal flaps and all this, and maybe off-label use even in stents, where you be careful you don't have to proceed if you're on the stent struts. And then probably then I would take the laser, because it's such a big, costly equipment. So that's always to be thought about.
Any other questions? I mean, I'll keep asking him all day long because I've got. So, what about when you're trying to cross a cap that you can't, a CTA with a difficult sort of type 3, type 4 cap? Have you used a laser without a wire just to get through the?
Yeah.
Is that? I mean,
yeah.
that's off, I presume.
Yeah. So if you want to be careful and you are a bit insecure, you use the 0.9 laser, which is the smallest one. I think Jos van den Berg from Lugano, he's done quite a few cases with a step-by-step technique. So you just lace, you put yourself on top of the cap, maybe it's with a sheath as well, so that it can't flip away. And then you just lace and you push your wire in, and then you proceed. But then you won't do a debulking. So that's a very, very small channel. And if you get out of the vessel, the bleeding can be stopped by prolonged dilatation. But then still you have got lots of material inside the vessel, then you still need to debulk. Yeah. So I think that's, otherwise you can use the hard tip of the wire just to pick onto the calcified plug and probably to move into the vessel and then proceed with the soft end of the wire.
And how about trackability? Is it quite good for up and over in terms of trackability, or are you often antegrade only?
No, it's a crossover because it's very flexible, which is different to other devices. Like my Rotarex snapped a few times if you have a steep angulation, a steep aortic bifurcation. And as well, the bicross device I'm using quite often, that's as well not good in steep bifurcation. That's a lot easier with the laser, definitely, because it's so soft and it can just go around if you have a 7 or 8 French teeth. And then you have less friction. So I usually, if I have steep bifurcation, I use a bigger sheath that I have less friction.
How about Raw 3? Do you guys find the Rotarex tracks all right up and over, or is that not?
So it's all to do with the iliac bifurcation angle. So typically what we look for is actually sort of distance. They talk about 4 centimeters being the crucial distance. But that said, I've not had too many trouble with it until I did. And it was when I pushed it too far and actually found that on that one particular case, I snapped 2 helixes. So it will stress, and when you stress it, you're going to weaken it. it's not going to work as well, and then ultimately you may well find that you snap it, which I've done. But generally speaking, it will track up and over, and I've done so quite successfully with the 8 French. But it's all to do with the angle of the bifurcation and it being not too calcified and rigid, because when there is some play, anything that straightens with a stiff wire, generally speaking, I think I've got away with. And I generally in those situations don't go a size bigger for the sheath. I'll go sheath size matched, and even then, if I'm putting a pressure bag on, which I generally recommend when you use Rotarex, whether it's anti-grade or retrograde, it's part of my practice to do that, it will be through the 8 French sheath, just with the pressure bag on. So no, I haven't had too many problems, as I say, until I did, and it was all to do with the angle.
Thank you very much for a wonderful talk, Prof. It's Conrad from London. I'm at IR. We have a small practice using the excimer laser, normally used for removing embedded cardiology leads, but we use it to remove things like IVC filters. And so we do have some of the hardware. Do you think it's worth getting a sort of a hybrid device that could do both? And does such a thing exist? And what's your experience, if you have any?
I think this is ideal, because if you share it with the cardiology or cardiothoracic surgeons, then it's at least in use quite a lot, and then it's worthwhile to have it. So I think you don't need different equipment. So the laser, it's always the same machinery. So you only have to buy the catheters. So that's really easy. And the laser definitely is, for me, for clearing out stents. So if you have like full metal jackets, SFA, which we have in the history done quite a lot and still do, if it's highly calcified. And then you can clear out the parastents, which is quite nice. And I use it with young diabetic below the knee for the below the knee vessels, because there's so much intimal hyperplasia inside the vessels, especially if they're young diabetic and smoking, and they come to your place, to your practice already when they're 40, 45. And what do you want to do with these patients? A distal bypass is the only treatment option if there's something open. Otherwise, a PTA, they will come back in 2 weeks. The vessel won't stay open. So you have to clear out the vessel below the knee. And the only device for soft tissue down there is definitely the laser. I can't think of any other treatment. The Stealth is for calcified stuff, maybe can be used down there. The Phoenix neointimal won't do such a good job as with calcified lesions. So the laser definitely below the knee, young diabetic, that's my best treatment option. And then DCB afterwards.
Thanks. Another question here. It's Narayan from London. Just to take things back to IVUS for a second, because I think this case showed it really well, that there was a technical problem at the distal end of the stent that was probably the reason why the stent went down in the first place. So just wanted to explore with you what would be your, because we know that when a patient comes to you with a blocked stent, it's going to be one of either two problems. Either there's a technical problem at one end of the stent that has been missed at the time of implantation, and that's led to sudden blockage or blockage over time, or there's been intimal hyperplasia within the stent. Obviously, IVUS is very helpful quality controlling the transition from stented to unstented to make sure there's no flaps that are going to put the whole thing at risk. In your practice, with IVUS reimbursement being what it is in Germany, how do you decide when to open an IVUS because you're worried that there's a technical problem at one end or the other of the stent that you want to really image and fix? And is it just something that you feel with the catheter or something you see on an angiogram?
Sometimes it's just by feeling. So I think if I have like a slow runoff or something, so I started with a good fast runoff with the Bernstein catheter down there, and later on it's impaired. There's a lot of there's a problem somewhere, or I have a subintimal passage and I want to know where I have to stent the re-entry and entry. So these are my indications. And as well, if I have really, really long occlusions, where I definitely know I will miss something out. If it's a short occlusion, I can clear it out with Phoenix or whatever, no problem. I just will use DCB afterwards. There's a quick runoff, I'm happy. But if it's long occlusion, like 30, 40 centimeters down to P1, P3 segment even, then I use the IVUS.
Matthias, do you ever use a filter during these cases, or is the embolization risk so low that you don't need to?
Yeah, definitely. So with laser, I don't. That is hard. So I've seen maybe 1 or 2 embolization, but that was more a technical problem, which I had. But with the Phoenix, where you have really highly calcified eccentric plaque material, and maybe like 5 or 6 of those in the SFA, then I definitely use a filter. And most definite if I have a 1 vessel runoff.
Any questions at all from the audience? Okay, well, look, thank you again. Thank you very much. That was a fascinating talk. We'll hopefully see you in person next time.
Yeah, thank you. And you have a great time.
Yeah, thanks.
Bye.
Just want to say, if anybody's at Link next week, Matthias will be there. He'll be on our booth, and he will be able to do a hands-on, in-person demonstration of laser and talk through the presentation again. So please feel free to pop along to the booth next week at Link. Thanks, Matthias.
Okay, bye-bye. Bye. Bye.
Cool. So it's 11:30 now. We're going to, I think, unless anybody has any burning things they want to discuss in the whole group now, we can break for lunch, and then the plan will be to start the workshops at 1 o'clock. So you've got some time for a relaxed lunch, and then meet in the workshop groups. Warren, does everyone know what groups they're in and where they're going?
In your badges, thank you. On your badges, there are groups allocated. Yeah, so you'll have about 50 minutes with each of the speakers, and then we'll rotate you around the rooms, so you'll get a good flavour of different things. And there is one session in here as well, just to have a look at the Phoenix device. Unfortunately, we had a couple of technical delivery issues, and so we have only 1 tablet in each room that you can have a look at, unfortunately. So, but the guys, experts with the cases, with the presentations, and with the IVUS runs, and they'll talk you through everything that you need to do. Okay, thank you.